Welcome everyone. Today we are going to discuss about the basics of febrile seizures in children, which is a very important topic to know for the effective management of children in the pediatrics department in the indoor as well as in the outdoor. So coming to the basics, seizures accompanied by fever, that is called febrile seizure. Now what does fever mean? A temperature of more than 38.4 degrees Celsius or 101 degree Fahrenheit, that is fever. Fever must be accompanied by seizure to call it as febrile seizure. But it must be without any evidence of CNS infection, metabolic disturbances, or history of afebrile seizures or any acute neurological insult. For example, any severe electrolyte imbalance, any meningitis or trauma. That in the children aged between 6 months to 6 years is called a febrile seizure. That means febrile seizure is basically a diagnosis of exclusion. What are the conditions that we need to exclude to call it a febrile seizure? We must exclude CNS infection, that is meningitis, encephalitis, all those things. Metabolic disturbances that can cause fever and seizures like dyselectrolytemia, hypo or hypernatremia, hypo or hypocalcemia, hypo or hypermagnesemia, and any other acute neurological insult like a recent history of trauma, any history of intracranial hemorrhage or any feature suggestive of intracranial hemorrhage or any neuroimaging evidence of intracranial hemorrhage. All those things must be ruled out before calling it a febrile seizure. This febrile seizure is seen in children aged between 6 months to 6 years, but it peaks at the age of 12 to 18 months. Now, what is simple febrile seizure and what is complex febrile seizure? Simple febrile seizure is called when it is usually tonic-clonic type of seizure. The duration of the seizure is usually less than 15 minutes and it usually doesn't recur within the initial 24 hours of fever. But when all these criteria are not met, that means either the seizure can be focal or it may last more than 15 minutes or it may recur within the 24 hours of fever. It is called as complex febrile seizure. Now what is febrile status epilepticus? If the febrile seizure lasts for more than or equal to 30 minutes, it is called febrile status epilepticus. What is febrile seizure plus? Any febrile seizure that continues past the usual age. What is the usual upper age limit of febrile seizure? That is 6 years. But if it continues past that age, that means beyond 6 years, and may be accompanied by afebrile seizures also. So it can be called as febrile seizure plus. Now coming to the special term, that is GEFS plus, that is generalized epilepsy with febrile seizure plus. What is it? It's usually a condition that is transmitted by autosomal dominant inheritance. In this condition, usually febrile seizures are seen with family history of one of the following. That means it may have family history of febrile seizure, the patient may have family history of febrile seizure plus, the patient may have family history of afebrile seizure also. That means family history of any of these conditions accompanied by febrile seizure in the patient, most likely autosomal dominantly inherited. We can call it as generalized epilepsy with febrile seizure plus or GEFS plus. So these are the common terminologies that are used in relation to febrile seizures. Now coming to some unaccepted terms, that means these terms should not be used anymore. Some of these terms were used before some times ago, but now it is discouraged to use these terms. Those terms are atypical febrile seizure, fever triggered epilepsy, febrile seizure alone, simple febrile seizure plus. I want you all to know that febrile seizure plus is an accepted term, but simple febrile seizure plus is not. So what are the common differential diagnosis of febrile seizure? So basically any condition that can cause fever and that can also cause seizure is a differential diagnosis of febrile seizure, because febrile seizure is a diagnosis of exclusion. So we cannot list all the conditions that can cause fever and seizure as its manifestation. So we have listed only a few common conditions. Some of them are acute disseminated encephalomyelitis, that is ADEM, acute pyogenic meningitis, aseptic meningitis, for example caused by scrub typhus or any viral pathogens, acute encephalitis syndrome, cerebral malaria, and benign childhood epilepsy. All these diagnoses have seizures and fever as their manifestation, so they are considered the differential diagnosis of febrile seizures. So how do we evaluate a case of febrile seizure? What I want you to know, and it's also an important MCQ for medical entrance examinations, that HHB6B followed by HHB7 is frequently associated with febrile status epilepticus. So basically any disease that can cause fever can cause febrile seizure. Out of them, HSB6B has been associated most frequently with febrile status epilepticus. So we need to do some investigations to rule out other potential life-threatening or reversible conditions with available definitive therapeutic options. The most important slide is this. What we normally do is whenever a patient of febrile seizure comes, or whenever a patient comes with febrile seizure, we are suspecting febrile seizure in that patient, we think what investigations are to be done. So what I want all of you to know is that no investigation is to be done routinely. No investigation is indicated in all patients of febrile seizure. That means there is no investigation which is indicated in all patients of febrile seizure. All the investigations that are to be done in a case of febrile seizure have some specific indications. For example, complete blood count and quantitative CRP is not required in all. It is required only in a cases of complex febrile seizure and febrile status epilepticus. Likewise, blood sugar is not required in all patients. It is done only in a case of febrile status epilepticus, that means febrile seizure lasting more than or equal to 30 minutes, if a patient is convulsing actively or if a patient has had complex febrile seizure. Serum sodium is not required in all. It is to be done in case of febrile status epilepticus and if the baby is having active convulsions. Serum calcium is not required in all. It is done only in cases of simple febrile seizure in an infant, that is age less than 1 year or less than 12 months, complex febrile seizure, febrile status epilepticus and active convulsion. Serum magnesium, it is not required in all patients and there is paucity of literature as to where it is indicated. Iron deficiency screening, that means iron studies or complete hemogram, is not required in all. It is done only if clinical pallor is present or if you have documented a low hemoglobin level. It is only indicated in those cases. Serum phosphorus, alkaline phosphatase, vitamin D3 level, all these are not required in all patients. It is to be done only if the patient has had some features of rickets or if hypocalcemia has been documented. Urinalysis, that is urine routine or microscopy, is not required in all patients. It may be considered in patients less than 18 months of age in absence of other focus of infection. So coming to the indications of neuroimaging in a case of febrile seizure. Out of all the neuroimaging modalities available, MRI is the preferred neuroimaging modality in a case of febrile seizure. But that doesn't mean that all cases of febrile seizure need an MRI. So when a case of febrile seizure comes, first we need to think whether it is a case of simple febrile seizure or is it a case of complex febrile seizure. So is MRI indicated in all cases of simple febrile seizure routinely? The answer is no. Is MRI indicated in all cases of complex febrile seizure routinely? The answer is not that simple. So we need to think whether this episode of complex febrile seizure is the first episode with prolonged, that means more than or equal to 15 minutes, or focal features, or this is a febrile status epilepticus. In these three scenarios, that means if the duration of the seizure has been more than 15 minutes, the seizure has been of a focal type, or the patient had presented with febrile status epilepticus and this is the first episode like such in a patient, then only the neuroimaging is indicated and it is to be preferably done within the first 72 hours of the seizure. That is the most important thing. Now after that, if the MRI we did not suggest any alternate diagnosis, for example any intracranial space occupying lesion or any demyelination or whatever may be, if it doesn't suggest any alternative diagnosis, we do not need to do a follow-up neuroimaging. On the other hand, if we found some suggestion of other alternate diagnosis in the MRI, then we may need to do follow-up neuroimaging. What we need to know here is why we are doing the neuroimaging, because we are doing the MRI to look for viral encephalitis or virus-associated encephalopathy, acute disseminated encephalomyelitis, whether there is any intracranial space-occupying lesion, whether there are any cortical malformations, or whether there are any hippocampal abnormalities which have had correlation with future development of mesial temporal sclerosis or medial temporal lobe epilepsy. So now coming to whether there are any indications of non-contrast CT scan of the brain. We learned that MRI is the preferred modality, but is there any condition in which a CT scan is indicated in a neuroimaging as the neuroimaging modality in a case of febrile seizure? The answer is no. But when we need to do, when there is history of trauma, because if there is any history of trauma, we need to rule out an intracranial hemorrhage, and for that the CT scan will be the investigation of choice. If the patient has had some status epilepticus, if the patient has had some clinical suspicion of raised ICP, if the patient has had some BP shunt, if MRI is indicated as told before but is not available, in all these conditions we need to do NCCT brain or non-contrast CT scan of the brain, because in all these conditions we may not have sufficient time to wait for an MRI to happen. If an MRI on an average will take 40 to 45 minutes, sometimes it will take 60 minutes also, but we may not have that amount of time in these scenarios. If there is any history of trauma, the intracranial hemorrhage may be increasing. If there is any status epilepticus, that means the child might be that sick and the patient needs to remain stable still inside the MRI machine for it to be done. If there is any clinical suspicion of raised ICP, it may lead to impending brain herniation. If there is any BP shunt, that means shunt meningitis, it may lead to shunt blockage and hydrocephalus. And if the MRI is not available, so in all these conditions, a non-contrast CT scan of the brain is. Now coming to the indications of electroencephalogram or EEG in a case of febrile seizure. Similarly, we'll approach just like we approached for neuroimaging. So do all cases of simple febrile seizure need an EEG routinely? The answer is no. Do all cases of complex febrile seizure need an EEG routinely? The answer is yes, we can do an EEG, but the EEG is of unclear prognostic significance to predict the future risk of epilepsy. That means if we do EEG in a particular child with complex febrile seizure and the EEG comes abnormal or having some epileptiform discharges, it doesn't necessarily mean that the child has increased risk of developing epilepsy in the future. So how we will use the EEG? So the answer is, suppose we have done neuroimaging for the first episode of complex febrile seizure having prolonged or focal features, as we learnt in the previous slide. If a patient of complex febrile seizure, first episode with prolonged features or focal features or febrile status epilepticus, in that scenario neuroimaging is indicated within first 72 hours. Suppose we have done that and the neuroimaging doesn't have any focal findings, then we don't need to do an EEG. But if the neuroimaging has suggested or has revealed some focal findings, then we need to do the EEG. So how do we do the EEG? We do the EEG within 1 week of febrile seizure or at the earliest feasibility. And the EEG should be a minimum of 30-minute record, which must include both sleep state and awake state. Now coming to, I think, the most important slide of febrile seizure. When to do a CSF analysis or lumbar puncture in a case of febrile seizure. So is CSF analysis indicated in all cases of simple febrile seizure routinely? The answer is no. Is a CSF analysis indicated in all cases of complex febrile seizure? The answer is no. So that means the simpleness or the complexness of the febrile seizure doesn't guide the indication of CSF analysis in a case of febrile seizure. That means there are some other factors. So what are some other factors? So first we'll see what is the age of the child. If the child's age is less than 1 year, that means the child is an infant, we'll ask for what is the immunization status of the child. If the child has been immunized against streptococcus pneumoniae and Haemophilus influenzae type B, immunized completely, That means the child has less risk of meningitis being caused by these two organisms. That means we don't actually need to do a CSF analysis in these cases. But suppose the infant is not completely immunized against Streptococcus pneumoniae and Haemophilus influenzae B, or if the immunization status is not known or undocumented, or the parents have forgotten, or they cannot show the evidence that the child has been immunized, then we should definitely do a CSF analysis in those cases, because there is increased risk of meningitis caused by these two organisms. On the other hand, if the child's age is more than 1 year, then what we will see? Then we will see whether the child has received some antibiotics before coming to the hospital. That means if the child has been pre-treated with some antibiotics. That means if the child is pre-treated with some antibiotics, that means the patient may actually be a case of partially treated pyogenic meningitis. So if we don't do CSF analysis in those cases, we may incompletely treat that patient, and the patient will end up in some sequelae like hydrocephalus or something else. So if the patient has been pre-treated with antibiotics, we will definitely do a CSF analysis. But on the other hand, if the patient has not been pre-treated with any antibiotics, then we don't routinely do a CSF analysis in all those cases. Some special scenarios, if the patient has had clinical features suggestive of meningitis at any point of time, if the child has had febrile status epilepticus, if the child is showing no improvement in sensorium after sufficient time interval, because in usually all the cases of febrile seizure, the sensorium returns to the baseline or normal maximum within 1 hour of the seizure. But if the sensorium has not returned to normal within 1 hour of seizure, that means there is high chance of meningitis or encephalitis in those cases. So that means in those cases a CSF analysis is indicated. So now coming to genetic testing. Although it is a uncommonly available thing, but still we need to know what are the indications. So genetic testing is usually done for Dravet syndrome. Dravet syndrome is otherwise known as severe myoclonic epilepsy of infancy. It is caused by a mutation in the SCN1A gene. How does it present? Usually the onset of Dravet syndrome is in infancy, that means less than 1 year of age. And how does it start? It usually starts as prolonged hemiconvulsive seizure, that means seizure involving one half of the body, and it usually recurs every 1 to 2 months. That means recurrent prolonged hemiconvulsive seizures or focal seizures are seen. Recurrent febrile status epilepticus may be seen, and initially the seizures are febrile, but later it may progress to afebrile seizures. So that means the TGs gradually gets severe and severe and severe. And it is also usually associated with atypical absence seizure, and it sometimes is associated with developmental delay also. So in those cases, if this type of history is present and there is a high suspicion of Dravet syndrome, we need to do the genetic testing for SCN1A gene mutation. Now, what are the other genes associated with febrile seizure? Like SCN1A, SCN1B, 2A and 9A may be involved. CPA6 gene may be involved, or GABRG2 gene may be also involved. Overall, a decreased interleukin receptor 1A to interleukin 8 ratio is associated with hippocampal abnormalities on MRI. I previously told hippocampal abnormalities on MRI are associated with future development of mesial temporal sclerosis or medial temporal lobe epilepsy. So a decreased ratio of interleukin receptor 1A to interleukin 8 is usually associated with development of hippocampal abnormalities on MRI. So a decreased ratio is usually suggestive of higher risk of medial temporal lobe epilepsy in the future. So now coming to the management of febrile seizure. There are basically 6 steps of management of febrile seizure in the patient. First, domiciliary care. That means how the seizure will be managed at home. Next, intermittent prophylaxis. That means do we need to give some treatment for seizure intermittently, not continuously. Third thing, continuous prophylaxis. That means do we need to give any treatment for seizure continuously. Antipyretic medications. What medications do we need to use to control the fever? Fifth, micronutrient supplementation. Do we need to give any micronutrient supplementation for the febrile seizure patient? And last but not the least, parental education. What we need to teach the parents. Coming to the first step, that is domiciliary care. That means what treatment needs to be given at home by the parents. So the parents need to identify and provide the first aid management of a febrile seizure at home, because it will take some time for the parents to bring the seizing child to the attention of the healthcare expert. So by that time, what the parents need to do, they need to put the child in a recovery position. What is a recovery position? As you can see in this picture, the patient has been turned to one side, that is left side in this case. Ipsilateral hand has been bent to prevent the rolling over. The contralateral hand has been put under the chin to keep the mouth open. The ipsilateral leg, that is the left leg in this case, has been kept straight, and the contralateral leg has been bent to support the position. This is called the recovery position. So doing this recovery position will prevent the chance of aspiration in the patient, and it will also minimize the risk of injury to the patient when the convulsion is happening. So the parents need to be taught how to make this recovery position, so that if a seizure happens next time, they need to do this immediately and first, so that there is minimum risk of aspiration and minimum risk of injury. Next, what needs to be taught? The dose and route of abortive medications. Abortive medications means the medications that need to be given immediately to control or stop the seizure. So what is the drug? The drug is midazolam, that is intranasal. When the child is convulsing, obviously we cannot give anything orally because there is the risk of aspiration. Obviously we cannot give anything intravenous also, because the child doesn't have a cannula, the child is previously stable at home. So the only route by which we can administer anything, the parents can administer anything at home, is the intranasal route. So midazolam intranasal is the drug of choice for the abortive medication for febrile seizure. So what is the dose? 0.2 to 0.3 milligram per kilo. It is the preferred medicine. If intranasal midazolam is not available, rectal diazepam or buccal lorazepam may also be used. And the indication of repeat dosing and bringing the child to healthcare facility has to be explained to the parents. So this is the midazolam intranasal preparation. Lots of brands are available. This is the dosing that I have shown. As you can see, each spray delivers a midazolam dose of 0.5 milligram per kilo. 0.5 milligram. So as I told, the dose is 0.3 milligram per kilo. That means, for example, a 10 kilo child will require 3 milligram. Each spray delivers 0.5 milligrams. That means to give 3 milligram, you need 6 spray. So that means roughly, for quick calculation, you can remember as, for a 10 kilo child you need to give 6 puff. For a 20 kilo child you need to give 12 puff. Half of the puff in one nostril, half of the puff in other nostril. So suppose a patient of 15 kilo comes and you are advising or explaining the dose and route of intranasal midazolam to the parents, you can tell that if the convulsion happens, make the recovery position and give the midazolam 4 puff each in one nostril, 4 puff in another nostril, total 8 puff to stop the seizure immediately. So coming to intermittent prophylaxis. Intermittent prophylaxis means if any medication is needed to be given intermittently, not continuously, so that the seizure will not happen. So first we need to understand what are the indications of giving intermittent prophylaxis. So the indications of giving intermittent prophylaxis are frequent recurrent febrile seizures. That means if the child is having frequent recurrent febrile seizures with any of the following: if the parents are anxious, if the parents reside in a place that is very far from the medical facility, or if the complex febrile seizure has not been started on any continuous prophylaxis. So in these scenarios you need to give intermittent prophylaxis. So what is the drug? The drug is oral clobazam. The dose is 0.5 to 1 milligram per kilo per day in two divided doses. Maximum is 20 milligram per day. for 3 days, and it has to be started when the child develops fever or while starting antipyretic medications. That means suppose a patient is there who has had multiple frequent recurrent febrile seizures in the past, and you have decided to give intermittent prophylaxis due to any indication. Suppose the parents are anxious and you have decided to give. So when will you advise the parents to start clobazam? When the fever happens or when the fever starts. That means initially day 1 of fever you will advise tablet clobazam or any oral preparation of clobazam 0.5 to 1 milligram per kilo per day in 2 divided doses. Maximum will be 20 milligram for 3 days. That means day 1 of fever, day 2 of fever, and day 3 of fever. On these days you will advise oral clobazam. So this is a preparation. One of the commonly available brands is Frisium. Some other brands are also available. Now, what are the indications of continuous prophylaxis? That means, is any medication needed on a continuous basis in a case of febrile seizure? So what are the indications? If the child has had febrile status epilepticus, that means febrile seizure lasting 30 minutes or more. Second, if the child has neurodevelopmental delay, for example global developmental delay, cerebral palsy, or the child has autism spectrum disorder. Third point, if the child has had frequent complex febrile seizures. Fourth point, if the child has had febrile seizure plus or GEFS plus with afebrile seizures. In these 4 indications, you will advise continuous prophylaxis to the patient. So what is the drug of choice? The drug of choice is sodium valproate. So this is an example of a preparation. Each 5 ml of sodium valproate solution contains 200 milligram of the drug, and the duration, how long you will give, till the child is 2 years seizure free. That means if the child after starting valproate becomes seizure free for 2 continuous years, then you will start about tapering or stopping the drug, or it has to be guided individually. There is no rule of thumb. So antipyretic medications, what you will give? The safest and the best drug that you can use is paracetamol, 15 milligram per kilo per dose, 6 hourly. How much duration? Till the patient becomes afebrile, or at least for the first 48 hours, because the first 48 hours of fever has the increased or highest chance of a febrile seizure to happen. And the justification for the round the clock administration, if it is there, it is confusing. So giving paracetamol, what we need to understand is that giving paracetamol doesn't prevent seizure recurrence or the occurrence. That means giving paracetamol will not prevent a seizure, or it will not prevent the recurrence of a seizure if one seizure has already happened. What the paracetamol will do? The paracetamol will make the child comfortable. At least that we can do. Is there any role of micronutrient supplementation in a case of febrile seizure? No. There is no role for empirical administration. If there is any documented micronutrient deficiency, then you can give. But if you don't have any documentation, if you don't have any proof, there is no role for routine empirical administration or supplementation of any micronutrient. Now coming to the last and most important step. Before sending the child home or before discharging an admitted patient of febrile seizure, you must need to explain the parents the following things. Why febrile seizures occur? Do they constitute epilepsy? What is the risk of death during a seizure? Do they lead to epilepsy or intellectual impairment? What is the risk of recurrence of febrile seizure? What to do if the child has fever? What to do if the child has seizure? What is the basic first aid and recovery position? What are the rescue medications and when to give? And what are the danger signs and when to bring the child to hospital? Out of these, this point 3 and point 4, I think these two are the most frequent questions asked by the parents, that do these febrile seizures lead to epilepsy or intellectual impairment in the future, and if there is any recurrence or if there is any risk of recurrence of febrile seizure in the future. So we need to know specifically these two questions. So what is the risk factor for developing subsequent epilepsy after a febrile seizure? Depending on the risk factors, there is risk of subsequent epilepsy. As you can see, that after a simple febrile seizure, the risk of subsequent epilepsy is 1%, which is same as the general population. So the occurrence of a simple febrile seizure doesn't usually confer an increased risk than the general population for the development of subsequent epilepsy. On the other hand, if the febrile seizure is recurrent, that means if the child has developed recurrent febrile seizure, then the risk of epilepsy is 4%. If the child has developed complex febrile seizure in form of more than 15-minute duration or recurrence within the 24 hours, the risk is 6%. If the seizure has occurred less than 1 hour before the fever, that means sooner or earlier development of seizure following fever, that means the fever has risen quickly, the fever has achieved its peak quickly, or there is an acute rise of temperature which has caused the seizure, the risk is 11%. If there is any family history of epilepsy, the risk is 18%. If the seizure was focal, the risk is 29%. And if the child has had some neurodevelopmental abnormalities, the risk of future development of epilepsy is 33%. That means almost 1/3 of patients with history of neurodevelopmental abnormalities who have had febrile seizure now will develop subsequent epilepsies. Now the point to be noted is that if a patient has had febrile seizure, almost 5% of those will develop epilepsy in the future. But if a child has epilepsy now, and if we take a history, we can see almost 15% of those have had febrile seizure in the past. Now, what are the risk factors for recurrence of febrile seizure? There are some major risk factors and there are some minor risk factors. So what are the major risk factors? Age less than 1 year, that means infancy. Onset in the infancy is a major risk factor. The duration of fever less than 24 hours, that means less duration of fever accompanied with seizure, that means acute steep rise in fever leading to a seizure. It's a major risk factor. And if the temperature is 100.4 to 102.2 degree Fahrenheit of fever, it is also a major risk factor. What are the minor risk factors? Family history of febrile seizures, family history of epilepsy, complex febrile seizures, daycare admission, male gender, and hyponatremia at the time of presentation. All these are minor risk factors for the recurrence of febrile seizure. So the presence of one risk factor, presence of no risk factors, confers a risk of 12% for the recurrence of febrile seizure. That means if there is no risk factor among these are present, still the child has a risk of almost 12% of recurrence of febrile seizure. But if the child has any one of these risk factors, the child has 25 to 50% risk of developing a febrile seizure. If the child has two of the risk factors, the child has 50 to 59% risk of developing recurrence of febrile seizure. And if the child has three risk factors, the child has 73 to almost 100% risk of developing a febrile seizure. Some special queries that parents usually ask: how to immunize a child of febrile seizure? Does the child need any different immunization schedule? No. The answer is no. Always we have to follow the IAP guidelines, that is the recent most is ACVIP Advisory Committee on Vaccination and Immunization Practice 2020-21 guidelines, and the 2023 guidelines are coming soon within a month. What is FIRES? Febrile infection related epilepsy or febrile infection refractory epilepsy. It is usually seen in more than 5-year-old male children. It's an encephalitis like illness, but no identifiable infectious agents are isolated, and the child is initially normal but later develops a difficult to treat epilepsy. That means multiple drugs will be needed, but the epilepsy will be very difficult to control. So now we will see two case scenarios that we usually encounter in most of our OPD and IPD practice. Case scenario 1. A 8-month-old child is brought to the emergency room with a history of fever for last 10 to 12 hours, followed by one episode of convulsion in the form of uprolling of eyeballs and tonic-clonic movement of all four limbs, which subsided automatically after around 10 minutes, and the child regained consciousness after around 30 to 40 minutes. So now the child is playful, active, stable vitals, low grade fever, and also has some runny nose and occasional dry cough. So basically we can see if we can rule out any evidence of meningitis, trauma, or any intracranial infection or metabolic abnormalities, This is a case of simple febrile seizure, most probably precipitated by the fever caused by an acute respiratory infection. So next question comes, do we need to do any investigations in this case? Yes, as you can see, there is only one indication of investigation in this particular case, that is simple febrile seizure in an infant of less than 1 year. We do need to do only the serum calcium. Rest all investigations are not required in these patients. Do we need to do neuroimaging in this case? This is a case of simple febrile seizure. That means we don't need to do any MRI in this case. Do we need to do an EEG in this case? This is a case of simple febrile seizure. That means we don't need to do an EEG in this case. Do we need to do a CSF analysis in this case? This is a child 8-month-old, that means age is less than 1 year, and as per the parents, the child is immunized completely against Streptococcus pneumoniae and Haemophilus influenzae B. That means we don't need to do a CSF analysis in this case. So, is hospitalization needed in this case? The answer is yes, because we need to do a serum calcium. Is any blood investigation needed in this case? Yes, serum calcium only. Is CSF study needed in this case? No. Is neuroimaging needed in this case? No. Is EEG needed in this case? No. So now coming to the indication of intermittent prophylaxis. Is any intermittent prophylaxis indicated in this case? Indication is frequent recurrent febrile seizure, and this is the first episode. So actually there is no indication of in giving an intermittent prophylaxis in this case. Is there any continuous prophylaxis indication in this case? Did the child have febrile status epilepticus? No. Does the child have any neurodevelopmental delay? No. If the child has had any frequent complex febrile seizures? No. If the child is a case of FS plus or GFS plus or afebrile seizures? No. That means there is no indication of continuous prophylaxis in this case. So, is any antipyretic medication needed? Obviously yes. Paracetamol will be given for initial 48 hours or till the child is afebrile. Is intermittent prophylaxis needed? No. Is continuous prophylaxis needed? No. Is domiciliary care to be advised to the parents? Obviously. What are the parental educations to be given? We have learnt all the steps. And what are the other supportive therapy indicated in this case? Yes, for acute respiratory illness, because we need to give acute respiratory illness supportive therapy in form of antipyretics, antihistaminics, nasal drops, and we need to explain the danger signs to the parents so that they will know when to bring the child to the hospital immediately. Now coming to the second case scenario. This is also a scenario that we frequently encounter in the hospital. So this is a 4-year-old child brought to the emergency room with active convulsion in form of GTCS with frothing from mouth, which the parents say has been going on for about 15 to 20 minutes. So duration is more than 15 minutes. That means it's a case of complex febrile seizure most likely. You administer abortive medications, for example lorazepam, and ensure normoxia, normoglycemia and normotensive state. The child's convulsions subside after your lorazepam and now the child is drowsy. Parents mention a history of similar episode same day 2 hours back, which lasted around 10 minutes. That means the seizure has recurred within the initial 24 hours. That is also a feature of complex febrile seizure. They also said the child has had similar events in the past, once at the age of 18 months and at the age of 3 years. They also have syrup amoxiclav, tablet clombazam and midazolam nasal spray with them, which they have given. So what do you do in this case? So we'll approach similarly. Is any investigation needed in this case? This is a case of complex febrile seizure which has had more than 15-minute duration, has presented to you almost 15 to 20 minutes and you have needed abortive medications to stop. That means this is a case of febrile status epilepticus most likely. The parents have told that these type of recurrent febrile seizures have happened twice in the past. That means this is the third episode. So what are the indications of blood tests in this case? All these conditions, complex febrile seizure, active convulsion, we need to do all these investigations. That means CBC CRPQ we need to do, blood sugar we need to do, serum sodium we need to do, serum calcium we need to do. Do we need a neuroimaging in this case? This is a case of complex febrile seizure, but this is not the first episode. The child has presented to you as a third episode. So we don't need to do a neuroimaging routinely in this case. But suppose we assume that the first episode that had happened at an 18 months of age and the patient or the doctor has done the neuroimaging in this case. Then we need to know whether that neuroimaging was suggestive of any alternate diagnosis, and assuming there is no alternate diagnosis, we don't need to do a follow-up neuroimaging in this case. Do we need to do an EEG in this case? This is definitely a case of febrile seizure, so we can do an EEG, but the EEG will not help us much in predicting the future risk of epilepsy. And assuming that the neuroimaging done at the first episode of febrile seizure did not have any local findings, the patient doesn't need an EEG now. Do we need to do CSF analysis in this case? This is a 4-year-old child, so we need to see whether the child has been treated with any antibiotics previously. As we saw that the child has a syrup amoxicillin, the parents have a syrup amoxicillin with them, so which they have given. So this is obviously a case with pre-treatment with antibiotics. So we need to do a CSF analysis in this case so that we can successfully or satisfactorily rule out a case of or a possibility of partially treated pyogenic meningitis in this case. So is hospitalization needed? Yes. Is blood investigation needed? What are the blood investigations needed? We learned blood sugar, CBC, CRPQ or quantitative CRP, serum electrolytes, mainly sodium and calcium. Is CSF study needed? Yes, to rule out a partially treated pyogenic meningitis. Neuroimaging or EEG are not needed in this case. Do we need to give intermittent prophylaxis? This is a case of complex febrile seizure which has not been started on any continuous prophylaxis. So there is an indication of intermittent prophylaxis in this case. So we need to give clobazam. Do we need to give continuous prophylaxis in this case? This is a case of frequent complex febrile seizures. So we need to give sodium valproate in this case. So is antipyretic medication needed in this case? Yes, paracetamol till the child becomes afebrile. Is intermittent prophylaxis needed in this case? Yes, clobazam. Is continuous prophylaxis needed in this case? Yes, valproic acid. Is domiciliary care needed? Yes, obviously we have to explain the parents. Parental education, we have to explain them the same thing. What is recovery position? How, when and how to give the abortive medications, at what dose and other things. And any other supportive therapy. Obviously, we'll need to give the supportive therapy as is needed in this case. So I hope all the residents have understood what are febrile seizures, what needs to be done in a case of febrile seizure. Mainly I want to focus on the indications of electroencephalogram, CSF analysis and neuroimaging in this case, which is the most confusing topic in a case of febrile seizure, and I hope they are all able to implement this in the future for better guiding the treatment of patients coming with febrile seizure. Thank you.